Hi, everyone. I'm Dr. Shen from Massachusetts Eye and Ear. I'm a glaucoma specialist, and I'm going to be talking to you about gonioscopy in this lecture. I want to first bring your attention to the website known as gonioscopy.org. And on this website, Dr. Lee Alward and colleagues have posted a lot of videos of gonioscopy, and I think you should review them because this will help to improve your skills and boost your confidence. When should you do gonioscopy? Now, before I show you the answers, I want you to think to yourself for a moment about how many times you have performed gonioscopy in the last week, if you were seeing patients last week, and if you haven't performed any, I think that it's time that you should start. We want to do gonioscopy on any newly diagnosed glaucoma patients. We want to do gonioscopy on any patients who has a shallow anterior chamber on Van Herrick screening, and I'm going to go over that when we go through the lecture. You want to perform on any patients with dramatic increase or decrease of IOP because a decrease in IOP may suggest a cyclodialysis cleft. And for any established glaucoma patients, you should perform gonioscopy every 5 years to see if there have been any changes to their angle. And also for patients who you're considering offering a laser or angle-based surgery such as iStent and trabectome, gonioscopy is important to assess the trabecular meshwork before you proceed with surgery. Why do we do gonioscopy? Gonioscopy means, gonio means angle and scopy means to look. And this is because the light that's showing the angle indicated here is internally reflected if you don't have an extra lens on there. So this is due to the Snell's law, and because this reaches the critical angle, we would not be observing any of the light that's reflected from the angle, and hence we cannot see the angle directly with the slit lamp. However, this is a condition where you can, and again, if you can think to yourself for a moment, what do you think this condition may be? This is a condition where the cornea is different from the normal population, and this is keratoglobus. There are two types of gonioscopy. There's a direct gonioscopy, which is using a high condensing lens with high index of refraction. And this is done usually when a patient is lying flat under general anesthesia and you walk around the patient's eye or the patient's head with a portable slit lamp because the light is traveling to the outside part of the eye. What we use in the clinics is indirect gonioscopy, which has a mirror or multiple mirrors where the light can be reflected to the examiner's eye. And this is a view of an examiner using an indirect gonioscopy lens. And this one has a handle. And you can see that this is done at the slit lamp. There are 6 steps to gonioscopy. We start with aligning the eye with the slit lamp. We need to dim the light and with the small beam, apply gentle pressure. We want to first identify the scleral spur. You want to look over the convexity of the iris to look into the angle. You can then indent the cornea to see if you can see more structures, and you want to record systematically. Here are some of the lenses that can be used in gonioscopy: Goldman 1 mirror, Goldman 3 mirror, Zeiss 4 mirror, and the Kepi lens. And I want to ask you this question. I hope you can think to yourself for a moment. Which one is used in direct gonioscopy? Remember, direct gonioscopy is performed with a patient under general anesthesia, usually with a patient lying flat. And the answer to that is the Kepi lens, which is down here. And in fact, we put BSS between the lens and the patient's eye to create a perfect suction with no air interface. And this is how we can observe the angle during examination on general anesthesia. The other question I have is, which part of the angle is X representing here? There's choice A and B. And again, think for yourself for a moment. This is using a Zeiss mirror, and you're looking at the superior mirror and you're looking at this part. And the right answer is B, because this is mirror image of that, not across 180 degrees. Here are the normal angle structures listed. You can see Schwabi's line, trabecular meshwork, scleral spur, ciliary body band. Here's another view. Again, I think sometimes the easiest to identify the iris first, identify the cornea, and realize that the bands in between start with trabecular meshwork down below, and then the lighter band of scleral spur, and then ciliary body band here. Here is just an illustration, again, reminding you of the structures, scleral spur, trabecular meshwork, and you also have, scleral spur is here. This is Schwabi's line. So again, trabecular meshwork, scleral spur, ciliary body band, and iris and cornea is up there. And so think to yourself for a moment, what am I showing you in this arrow? And the answer here should be iris. And here you're seeing ciliary body band. Here you're seeing scleral spur. Here you're seeing trabecular meshwork. And here you're seeing either Schwabi's line or cornea. In some of these normal angles, patients may have iris processes. And in this particular angle structure that you're seeing, the trabecular meshwork is here, and there's very little pigment in the filtering part of the trabecular meshwork. The iris processes bridge the angle, but do not actually draw the iris up to the angle. They're different from peripheral anterior synchronicae, and they do not impair the drainage function. However, when you're performing SLT, you do want to be mindful of these processes and try to skip them, as you can get IOP spikes and pigment dispersion by lasering these iris processes. Here's a 15-year-old patient with ocular hypertension. The past medical history is negative. And what you're seeing here, these red marks are the major iris circle, which are normal iris blood vessels. And this is different from neovascularization of the iris, which I have a picture later to show you. Here's an example of posterior embryo toxin, which is a ridge-like thickening at the anterior border of the trabecular meshwork. And you can see that here, the patient does not have glaucoma or abnormality, other abnormality of the angle. And in fact, about 15% of normal patients have this posterior embryo toxin. I want to go over the Van Herrick's method, which is performed at the slit lamp. You narrow the slit beam onto the cornea, just anterior of the limbus, and keep in mind this is not a substitute for gonioscopy. Here's a table to go over the grading system for Van Herrick's and how much of the beam you actually see and how that relates to the risk of angle closure. And here's an example of that. First, you measure how much of the beam is going through the cornea. And this is a grade 1, where only a quarter of that beam is between the cornea and the iris, in other words, in the anterior chamber. And this is a very shallow anterior chamber. Whereas this is a grade 4, where more than one thickness of the cornea beam is shown up here. So this is the ray of light on the cornea. Here's the ray of light on iris. And you can see there's a big gap in between. And this is a patient who's has more than 4 grade of Herrick, because you see how deeply recessed the iris is. And can you think of this condition that produced a hyper deep anterior chamber on Van Herrick's screening? Think for a moment to yourself. And this is angle recession, and you can also see some sphincter tear here in the iris. This is a patient who had trauma to the eye. Now, when we move on to gonioscopy, there's also classification schemes. There are multiple, the shaper, the shade, the spade, and describe what you see. The best way to think about classification of gonioscopy is that you should learn one system and learn it well so that you can be consistent over time. Here's the Schaefer grading system with grade 4 being very deep in the angle, and grade 1 being that you can, grade 0 where you cannot see any angle structures. The spade classification system, which is the one that I have been taught to use, is a little bit more complicated because it has a letter, a number, another letter, and then some descriptions. So to start, the letter D here is the iris root insertion, and this tells you really what structure you're seeing. And D means that you can see all the way to the ciliary body band. The number here indicates the angle width and how is the iris with respect to the cornea, and you can see the angles measured here. And the other letter here is describing the iris configuration, steep, regular, and queer, where the iris is bowing backwards, which is common in pigment dispersion syndrome. Then we describe how much pigment is in the trabecular meshwork and if there's any PAS or neovascularization present in the angle. This is a way for someone to document the angle with the 4 quadrants because you have 4 mirrors on your lens. And just remember that the superior mirror is viewing the inferior angle, the nasal mirror is viewing the temporal angle, but the actual left and right are kept the same, going up to down, and the actual up and down on the nasal and temporal mirrors are going across like this. So here you can see this patient has grade 4, which is open angle, but has PS in one of the quadrants and has early neovascularization in the other side. And this is to use the documentation method known as describe what you see, where you see ciliary body band here, you see PS and neovascularization. Once you get comfortable looking at the angle, then you can try indentation gonioscopy, which basically means that you're pressuring the dome of the cornea a little bit and forcefully open the angle. This is used to assess oppositional angle closure versus sneaky angle closure. You can use this to assess plateau iris syndrome. I will show you an example of that. You can differentiate it between a pigmented Semple-Lacy's line from a pigmented trabecular meshwork. And Semple-Lacy's line, even though it's more common in exfoliation syndrome, it can be seen in normal patients as well, at least also in primary open angle glaucoma patients. And basically what it means is that the non-pigmented trabecular meshwork is now filled with some amount of pigment. And indentation gonioscopy can potentially relieve acute primary angle closure glaucoma. However, it's not very effective in practical terms. Before I move on, I want to ask you a question. Which gonioscopy lens can be used for indentation gonioscopy? And your choices are Kepi, Zeiss 4 mirror, Goldman 3 mirror, all of the above, or none of the above. And again, think for your moment to yourself. And I just want to remind you before I go to the right answer is that you do need a lens whose diameter is smaller than the dome of the cornea. So that way you can actually apply that pressure and cause indentation gonioscopy. And hence, to go back to the question, the right answer here is Zeiss 4 mirror because the diameter is smaller than that of the corneal dome. Other lenses which you can use to perform indentation gonioscopy include the Posner lens and the Sussman lens. Now here's an example of a patient who seemed to have oppositional angle closure where there's no trabecular meshwork visible, and we perform indentation gonioscopy, and now you can see the trabecular meshwork and you can also see the sclerosphere. And this is a patient where before we do indentation, the trabecular meshwork is very lightly pigmented, but with indentation, sometimes you can see blood reflex into the Schlemm's canal, which helps you to identify trabecular meshwork. And of note, this is an African-American patient, and keep in mind that the pigmentation of the skin does not correlate with pigmentation of the trabecular meshwork. Here's a patient who has sneaky angle closure, and you can tell this is indentation gonioscopy because you see these striae, which are indicative of pushing on the cornea. And if you see the striae, that means you are indenting the cornea. And here you can see these PAS, which are these triangular shaped adhesions of the iris to the angle. Now, for those of you who are starting to perform gonioscopy, again, keep in mind of these striae because often beginners tend to push too hard on the eye and you may be creating striae inadvertently. And what happens is that it's actually harder for you to see the angle. So if you see those lines, actually what it means is just ease up on the pressure a little bit and you probably will get a better read. And here's an example of a patient who happened to have a simple Lacey's line, and with indentation, you can see here's the actual trabecular meshwork, and here's closed spur, and here's the ciliary body band. And this line above, like I mentioned earlier, is known as simple Lacey's line, or the non-pigmented TM getting pigment. And this is a patient who had a PI or prefer iridotomy for occludable angle, who happen to have some Lacey's line. But with indentation, again, you see the corneal stria here. You see less of it here, you see way more here, which means that the pressure is being applied. Notice also the S-shaped iris contour, which suggests this patient may have plateau iris syndrome. And here's a UBM picture of a patient with plateau iris, where the iris is relatively flat, and there's a very steep insertion of the iris at the angle. There's anterior rotation of the ciliary processes, pushing the iris toward the angle, so that even when the patient has a PI, there's potential angle closure. I will discuss plateau iris even more in the primary angle closure glaucoma lecture, which you'll be hearing in August. I want to show you some examples of pathology on gonioscopy. Here's a 30-year-old woman without any ocular symptoms, and she actually has no glaucoma. She has a 1-year-old daughter with correctopia and polychoria, but no glaucoma. And what do you think is the diagnosis? This is an example of Axenfeld-Rieger syndrome. As you can see, there is some iris adhesion actually to the posterior amblytoxin, which you can see here as well, but does not necessarily relate to the degree of glaucoma in these patients. And these patients may not develop glaucoma, but can have glaucoma. Here's a patient, an 18-year-old who had blunt trauma and hypotony, as in low pressure. And you see this arrow pointing to here. And what do you think that's about? And this is a patient, both for this patient and the patient image shown here. These are examples of cyclodialysis cleft, and what you're staring at here is actually varicella. And you can see that again on a UBM image where there's a clear path between the anterior chamber and this suprachoroidal space, and this is why the hypotony. Here you see a smaller cyclodialysis cleft indicated by the blue arrow. And keep in mind that these can be difficult to see because of the low IOP, shallow anterior chamber, and cornea is more likely to be distorted by gonioscopy lens. So sometimes you do have to fill these eye with viscoelastic to be able to see it better. Here's a 27-year-old with type 1 diabetes who had pars plana vitrectomy, silicone oil for tractional RD. And you see this round structure here, and the question is, what is it? And are we looking at the superior angle or inferior angle? And the answer is you're looking at the superior angle, and this is probably silicone oil that has traveled forward to the anterior chamber, and remember oil float, so it's actually at the top of the eye. Here is an example of very heavily pigmented TM, and remember the backbowing or the queer configuration of the iris. This is consistent with pigment dispersion syndrome. And here's another example of pigment dispersion syndrome. This is in contrast to sample Lacey's line, which is more commonly seen with exfoliation syndrome, where you see that the trabecular meshwork is here, but you see this line in front of it, but the pigmentation is not nearly as dense as pigmentation syndrome. And this is sample Lacey's line. Here you see these bridging red blood vessels. This is early neovascularization glaucoma or neovascularization of the angle, where the angle is not closed yet. In later NVG or MVA, you will see a red band here, and you will not be able to detect the blood vessels, these fine lacy vessels, as clearly. This is a patient with aniridia, and you can see the ciliary processes behind the iris on gonioscopy. And this is a patient with an iris tumor. And here's an example of PS, where you see these triangular peaks of the iris being adherent to the trabecular meshwork. I want to briefly discuss some of the imaging technology that's used to assess the angle in addition to gonioscopy. Examples are anterior segment OCT and ultrasound biomicroscopy. Here's an example of an eye. This is on gonioscopy image, and here's with the Visante OCT, and you can see the structures which are indicated here, and you can see the correspondence. And there have been many studies to show that it's actually pretty difficult to replace gonioscopy with OCT or anterior segment OCT. And this is an example of another OCT machine, the Zeiss Heidelberg, the Cirrus OCT. Again, you can see Schwabi's line, you can see Schlemm's canal, but you will not be able to identify structures such as, vessels in the ankle very easily. You may not, obviously will not be able to see the pigmentation, so it still does not replace gonioscopy. There is definitely correlation between gonioscopy and ultrasound biomicroscopy, and it's generally pretty good in terms of stratifying angles into occludable, closed versus open. However, again, keep in mind that none of the imaging technologies at this time can replace gonioscopy, and it's really important that you practice gonioscopy as much as possible. So in conclusion, there's really no substitute for gonioscopy in terms of seeing the fine details such as new blood vessels. Indentation gonioscopy can have diagnostic values and less so for therapeutic impact. Practice makes it easier, so please gonio your patients often. And the most common cause of an incorrect diagnosis in glaucoma is the omission of gonioscopy. So please try to continue to practice gonioscopy and improve your skills that way. Thank you for your attention, and I hope you have learned a lot, and I hope to see you during the live sessions as well.